Thank you for coming tonight. This is the trans, non-binary, and intersex affirming panel. As Sabrina said, my name is Ames Babich and my pronouns are they, them, theirs, and I am the program manager at the Eating Disorder Foundation. And we are very, very lucky to have Dr. San Chang and M. Reem Efrak with us tonight and talk a little bit about them before we dive into content. Dr. San Chang is a Chinese American gender fluid non-binary psychologist and trainer who has been in practice for 15 years. Their work is focused on intersectional body liberation, and they co-authored a clinician's guide to gender affirming care, as well as the APA guidelines for the psychological practice with transgender and gender nonconforming clients. Much of their work is focused on gender, sexuality, and disordered eating from an anti-diet and HAES perspective, as well as addictions, trauma, and EMDR. They are a certified body trust provider and have designed online education to help people heal from diet culture. And then M is a trans non-binary art therapist, fat activist, and artist whose work focuses on body justice, intersectional social justice, and treatment equity access. They are the co-owner of Rainbow Recovery, where they support people through the gender affirmation process, complex trauma recovery, eating disorder recovery, and body image issues. They do similar work for Walden Behavioral Healthcare, where they are focusing on the promotion and creation of LGBTQIA2+ centered care. And they also serve on the board of directors for Project HEAL, and an adjunct professor at Albertus Magnus College, where they teach multicultural practices of art therapy and eating disorder treatment and art therapy. So we have quite the knowledgeable experts on our panel tonight. And one thing that was a part of just the reminders as you all received for this is that there was some Trans 101 content to go over. So we'll be using language like transgender, intersex, non-binary. And so if you're unaware of that, we're not really giving a 101 here, but if you wanted to refer back to that, please do. And so Sand and M, is there anything I missed in your introductions?
I don't think so.
Lovely.
Think of anything either.
All right. And so I think for starters, the first thing I really want to just discuss with the two of you. So, you know, I feel like the word affirming care in general, much like trauma informed, seems to get thrown around a lot these days, and maybe not necessarily practiced. And so I'm wondering, you know, within your own fields and your own areas of expertise, what affirming care and gender affirming care means to you both.
So I look at the phrase affirming care the same way I look at the phrase trauma informed, which is like, that's the bare minimum, right? The bare minimum when we work with anyone who's trans, gender nonconforming, non-binary, intersex, or human in general, is to be affirming, is to be trauma informed. So we're asking for a minimum ethical standard. There are models for both trauma and working with people from oppressed and marginalized populations that go above and beyond that, but it doesn't seem to have hit the eating disorder world yet in the way that we need for it to serve the clients that we're working with or ourselves.
Yeah, I feel the same way. I mean, I think when I hear these terms, I wish that they didn't even have to exist. Like the very existence of them really kind of calls out the fact that so much care, if you don't call it trauma informed or you don't call it affirming, is sort of by default not those things. And so I'm just really looking forward to a time when these ideas are just kind of obsolete. And when I think about gender affirming care, you know, I think working in trans health, it's really easy to go towards a place of thinking about gender affirming care as only related to transition or medical transition. And I think gender affirming care is any kind of care that is inclusive and supportive of anyone walking to any kind of medical office. So trans person walking in to get a flu shot, you know, like that is an opportunity for gender affirming care. So it's not just hormones and surgery.
Agreed. That's the point that seems to get missed, right? That affirming care somehow means we have to go through those medical processes. And then that equates, are you trans enough, non-binary enough, intersex enough, if you don't want to go through those things. So it feels like there's so much more to unpack there.
And I think even just saying like the affirmation comes from the environment. I think we're relational beings. And so of course we care about how other people are responding to us, but also just this idea that like, I don't know, sometimes I think, why does it have to be in the role of the perceiver or the other to make it feel safe for us? And that's the reality, because we do live in a culture that is so violent and transphobic and fat phobic and racist. And, you know, so unfortunately it is, we rely on our context and environments to, you know, provide security and safety. But it's just, you know, I just think a lot about like, how is this affirmation, even the power of affirmation, come from the external environment?
And really, especially when we think about to affirm, that is to, especially in terms of, you know, providers and those who want to be allies, it's to affirm someone else, not necessarily to affirm the comfort of yourself or your perception or what makes you comfortable. It's literally to meet that exact individual where they're at and their comfort levels. And so then, you know, gender affirming care should be foundationally and inherently trauma informed as well, if we're to use both of those words. And so I really appreciate you both just sharing that as well, because like I said, I think so many times we see these words, especially when it comes to, you know, trans, gender expansive, intersex, non-binary individuals, and how to be trauma informed and gender affirming, when really a lot of times we're also not even asking each individual what's affirming to you, right? Because it is so individualized, and what's affirming to me is not necessarily affirming to M or to Sand either. And so just it's not always a blanket statement. It's really being able to meet people where they're at.
Yeah, I think I'll just say something in response to that is like, yeah, I mean, I've written a lot about gender affirming care and I talk about it, but I even sort of question this idea that there's one way or some kind of instruction manual, like this is how you do affirming care, because it's so culturally situated. And I think that everything I'm saying, everything I'm writing is going to be completely, it's not going to actually apply, you know, in a couple years or 5 years or 10 years from now. And so I always just tell people it depends. And really affirmation is not about learning rules. I think people, you know, because they're so scared of, you know, messing up, there's some, you know, a lot of us have a part that wants to learn the rules so that we don't have to mess up and we don't have to feel shame. But I think really it's about the listening and centering of the person that's right in front of you. And that's really what affirmation is about. It's not, okay, I learned this about this pronoun and I learned this about this word, which I think is inherently colonialist.
Yeah. And really just showing up as not an expert in the field, but an expert in today, an expert in your experience today, because like you said, everything will always be changing, and hopefully we allow that, because that's the only way we can grow, is by making mistakes and learning more information and allowing there to be much more of an expansive and continuous dialogue, not necessarily an answer. And then even on that topic, what do you see kind of more specifically as the barriers in the eating disorder field to trans, non-binary, and intersex people in receiving affirming, gender affirming care, trauma informed care? What are you seeing kind of the walls that have been put up, or the barriers that a lot of, you know, your clients have been facing?
I'll let you go, Em.
I was feeling I could talk about this all day.
I mean, yeah.
I mean, I think number one is when I call a treatment facility and they ask me, do I want a women only program? So I'm finally ready for help. I finally accepted that my eating disorder is at the point where I need a program. And my options are, we know there's almost no men's programs, and men's programs that exist are not trans man, trans mask friendly. Women's programs will sometimes take people that identify outside of the binary system, but then you have to have your own room, or there has to be all this conversation. And then why would I want to go through that? That's not affirming. That's othering, that's outing, that's oppressive. Then when I look at applications for treatment facilities, most are not really good at giving options of what to fill in, right? Is my gender even listed? Why does my gender need to be listed? What does that have to do with the fact that I need treatment? And then if we really want to break it down, how many treatment facilities have trans, non-binary, or intersex therapists that are qualified to treat eating disorders, that can model for me, that my face can look back at me in my worst moment and I can know? We don't provide that in this field yet. We are working on it. I believe we are working on it. I know I'm in situations where I'm working on it very actively. And I know for me, it was a big barrier for my own treatment, was finding anybody that could model for me who I was trying to discover to be in that process. And it's my greatest gift to be able to model that for my own clients, but it's one of the biggest flaws in our field.
Thank you. I just love everything you just said. And also I just need to name that when I'm looking at you talk, I'm just like so amazed and fascinated by your glasses.
Oh no, should I take them off?
No, they're awesome. But I just I think a part of me just needed to name, like, oh my God, I'm like loving your glasses.
Thank you. This is meant to be Elton John in public.
So I guess, I was thinking about like, barriers, and like expertness is a barrier. And I think part of it is that like in most fields, expertness is really like seen as the thing you want to be, right? You think you want to attain. And so then we have people who have completely devoted their careers to trans health. And then we have people who have completely devoted their careers to the eating disorders field. And there's very little communication between these two fields. And there are some of us who kind of, kind of shift between the two. But I think there's just not enough communication. One of the challenges is that there's sort of cultural norms in each of these fields. And so it's even hard sometimes to even translate what's happening. And then I think another barrier is just that, and maybe this doesn't need to be said, might be obvious, but just that the eating disorders field is so much situated around a very limited, narrow stereotype of this is who suffers from eating disorders. And it really leaves out pretty much, most of the people who even struggle, right? Like if you're told that your body is not a good body, then that's going to put you at a greater risk for an eating disorder. So disabled folks, fat folks, trans folks, people of color. So, I mean, it's really hard when the eating disorders field is already just so behind at being able to treat anyone outside of this very limited idea of, pretty much white, cis, straight women.
Agreed. Oh my gosh. And how about like basic stuff that isn't necessarily just a transgender nonconforming intersex problem, but cost? Mm-hmm. And I know most of the trans clients that I have that have decided to go through the medical process have had to choose, do I pay for treatment or do I pay for surgery? Which one will end up being more affirming for me in the long run, right? So there's that, right? Just as a blanket problem in the eating disorder world.
And how impossible is that when your eating disorder acts or your diagnosis acts as a barrier to surgery? Yes. Or your weight or your BMI acts as a barrier to surgery, then it's like just, a lot of times there's a double bind there, and including even just going back to how much like requiring trans and non-binary folks to see mental health providers to get letters actually is a setup. It increases a sense of stigma, and then there's this ableism that then gets perpetuated, and then trans and non-binary folks who really do need therapy or mental health care feel like there's even a bigger barrier there. So I just think, gosh, this is a tangled mess we have. And then you get down to an individual level of how do I help this person? And, everything you said, about trying to find treatment options. It's like, I get so many emails and like messages about, I'm trying to place this person, they need, any inpatient residential treatment. Where's the place to go that's trans affirming? I'm like, I actually can't refer you anywhere with confidence.
Agreed.
That's really discouraging.
Agreed. And I mean, obviously I work at a facility part-time right now, and I can say that there are places that are working on that and that see that, but we're not there yet. And so what do we do today with the clients today, that when we all get off of this call, we're going to have those emails to answer?
Mm-hmm. Yeah. And I will say, like, things have shifted in the past few years. I've gotten way more requests from treatment centers, way more requests from, eating disorder conferences. So there is kind of a little bit, or maybe a lot more awareness around how much disordered eating or eating disorders affects trans and non-binary communities. But the resources given to training, it's really limited because, most of the time it's 1 hour. And a lot of that 1 hour is based on some 101. And by the time we're done with that, there's not even enough time to really talk about the ins and outs of treatment and how we can't actually even use the same frameworks to treat eating disorders with trans and non-binary folks.
Agreed.
One thing that really stuck out to me, Sam, that you kind of were sharing too about the experts in both field, like the experts in trans healthcare and then the experts in eating disorder field, is it's really hard because then it's like needing to swap 101s, right?
Oh yeah.
And then you're almost at square one each way. Yeah. And so how does someone stay involved and educated in both? And in my brain, I'm like, the solution is, you're always a student, right? In so many ways, just being open to always being a student, because, there has been so much more language even in the trans community that's been included in the past decade. And the trans community, we're all still students too, and just being allowed to continue learning. I think it's almost like allowing yourself to not be an expert and to be learning and to be making mistakes, because that's a huge part of the human experience and about being able to meet people where they're at.
Agreed. And I mean, to that end, I feel like when we put ourselves in the power position of being expert, which I think Sandy labeled so well before, is like, that's a function of colonialism right there. Is there's a position of power where I am the expert, I know everything, you as the client therefore know nothing, right? That not only does that not work, but then if you as a clinician want to come and learn from me, I'm the expert, I know everything, it's my job to impart the knowledge on you, which creates more gatekeeping and more barriers to more clinicians learning, because eating disorder treatment knowledge is expensive.
Yeah.
This is expensive. I tell everyone, the biggest privilege I have is being able to do this work because I've had to pay for the education to do it.
Yeah. And I would say the same goes for most of us didn't get eating disorders training or trans health training in any kind of, if you're a provider, I know not everyone here is, but if you're a provider, most likely you didn't get the training you need to be able to do work in either field. And so you have to pay more. It's already so hard to kind of be able to achieve or like attain higher education because of barriers and disparities. And so what it then does is that specialists or experts do tend to, have more privilege. And I know that, like, I have this education because I was able to access it, because I had, access to material resources. right? So, and even this, I liked how you said, like, Ames, swap 101, because I literally do that. I'm thinking, okay, I have a training, it's for an eating disorders conference. I got to get a bunch of like basic trans stuff in here so that we can even have a conversation. Okay, it's a, trans health conference and we're talking about eating disorders. I need to even let them know what eating disorders are, what these diagnoses are. So I literally do that. Like, I have to think, oh gosh, okay, where do I back this up? And even I just struggle so much with the concept of 101, even because, I mean, one of my favorite books that I tell everyone to read is Decolonizing Transgender 101. It's just, usually have it like right here. I don't have it right here. It's just, I mean, it's just so smart and really challenged me in how I thought about gender, and really challenged me in how I have already done this work, in trans health. And so highly recommend. And then the other thing I was going to say is, oh yeah, and then both fields, the eating disorders field and trans health fields, really suffer from some version of founder syndrome. And so I talk about this a lot, but just that there is that gatekeeping, and that sort of the way the academy owns these fields. And because the academy is like a slow moving, very just kind of stuck place for a lot of new learning, and knowledge acquisition, that it just, I think some of the most interesting things that are happening are completely outside of that realm. Like, people are like, how do I keep up to date on this stuff? I'm like, I actually think a lot of the most interesting stuff is happening in conversations on social media, which I, of course, have a love-hate relationship with. But that's where I think, I'm reading the most interesting and things that challenge me and how I think about things.
Agreed. And like, to that end, I just want to kind of label, as it's in my head, some of the most marginalizing and traumatizing experiences I've had professionally have come from experts in the field who say they know more, who are heads of these organizations that tell us how to do our job, but cannot apologize for misgendering, a wrong pronoun, using a wrong name, being inappropriate. And that's who's teaching clinicians. So if that's what's being modeled for clinicians, what are our clients dealing with? And I just feel so terrible for every person who's on here, who's not a clinician, who's a client, who's hearing this, but know that like my empathy and love for you is so deep and so great, because I know that what you have been set up for is not fair. And that's why we're having these conversations, is because something needs to happen that's more equitable than what we're experiencing.
Yeah, it's super, I'm like enraged a lot of the time that the places where people are looking for help are the places that can be the most harmful. Going to a surgeon or going to a doctor or a therapist, especially, I think I get the most upset about that. I'm like, do you not have like interpersonal skills and empathy? But that's what happens. And, then what happens when you can't find a good provider? That's even more resources. That's even more, like, every time you have to like extend to try to find someone, that's a barrier. And so it's a real problem. I don't want to be like all problems all the time, but like that's where we are. I mean, I think what has progressed is there's more conversation, there's more awareness, but for the most part, systems that have power and impact really haven't shifted enough to provide affirming care.
So to give us a positive spin, I want to say one of the places I'm working at now, whenever the clients give feedback, I actually get to bring it to the VP of clinical operations, and then she does something. And it's really been amazing to watch clients be, specifically the queer clients in particular that I work with, are being told, if you give me feedback, I can bring it to the places. And then the people in the places actually do something with it. And what it's proven to me over the last few months is actually this change is really possible, and it's affordable, and it doesn't harm the clients or the clinicians. So why are we so stuck on not doing it? Because I'm watching it happen.
Absolutely. And I think also a lot of this is reminding me of the power of peer support and mutual aid, because, you know, I'm very lucky enough to run a trans non-binary eating disorder support group. And so often, though, people are saying this is the only place I expect to not get misgendered, right? And even in you know, care settings and things like that, but just really allowing people to find their community, I feel like, and encouraging that is super important too, because especially, you know, when individuals have to go through treatment, anyone, trans or not, like, that is not the world in which we want people to live in, right? We want people to live in the world. And so being able to find your community of people and encouraging people to build their own support systems. And people shouldn't have to build their own support systems because they're going to get harmed nonstop, but just really encouraging people to find that mutual aid and peer support too, I think is really important. And I know we've touched on a bit of this, you know, as we're talking about barriers, but I'm also wondering where, you know, we brought up obviously colonialism, cost, but just really highlighting some root causes that cause all these barriers. I know that's a really loaded question, and if people need to do their own research, which everyone always should be doing, but just kind of touching base on the biggest, potentially the bigger or biggest root causes that you see or you run into a lot.
A lot to say. I don't even know. Maybe I'll just start and say that, like, when we even say the term eating disorders, it does automatically conjure up like some stereotype or pretty limited DSM diagnoses that don't fit for everyone. And so I've really been thinking a lot about how these frameworks for eating disorders actually might not even apply. Like, I'm thinking about this as totally different pathways, actually. And, you know, a lot of times when people, and I think for people who do fit the stereotype, it's not as simple as I want my body to look like that person's body. And I think that that's usually the very common experience, but overly simplified way to understand eating disorders, because we're neglecting to talk about resources, talk about, you know, the assumption that someone even has access to food and feels safe accessing that food if it is available to them. So there are lots of ways that poverty and disparities really feed into eating disorders that I think aren't really talked about enough. And then minority stress, or just what it's like to walk around in the world and have a heightened sense of fear, trauma, heightened need for coping, that then makes it necessary to reach out for something else, a substance or an eating disorder or some other kind of way to cope that is not bad, it's survival. And so, you know, I think it's not just about the aesthetic. And so I want us to get past the aesthetic.
Agreed. My biggest, I guess, gripe of our field is that the root cause is, you know, the thing that the whole country seems to be talking about, and rightfully so, right? It's white supremacy. So when the stereotypical eating disorder patient is a thin, cis, hetero woman who's usually, you know, blonde hair and blue-eyed, right? We see what we're being presented with. And so if our field is founded on this kind of supremacist viewpoint of what a human being is supposed to look like, and therefore all the diagnosing and all the treatments are being created based on that stereotype, of course everybody else is left out. And here's the problem: it's actually everybody else that has all of these issues because nobody fits into a dominant narrative that doesn't exist.
Yeah, and just to add, like, just you know, how do I want to put this? Is just like our binary gender systems, they don't just exist, right? They're not just here as a fact, even though that's what we've all been trained to believe. It's because of colonialism. and white supremacy that we have these such limited views of gender, when in fact gender variance, gender nonconformity, some kind of, maybe not these words non-binary, but some, some kind of expression that outside of a binary really has existed across centuries over every continent. And so when a trans person goes into an eating disorder setting and experiences transphobia or the imposition of the binary, they're directly facing the results of colonialism. There's that. And then there's this history around, how do we think about like, what's good food, what's bad food? Like that also comes from, this history of settlers coming in and saying, let's clean up the diet of the indigenous folks, and so we can go into the history of eating disorders and diets, we can certainly go down that road, but there's a lot there around imposing like, this is the superior way to eat. And even the settlers were worried that if they ate foods that were part of an indigenous diet, that they would become more like indigenous people. So there was a real push to like, kind of, let's get rid of these food practices. I'm oversimplifying this, of course, I'm non-expert on all this, but I think it's just really important to call out that, there are just deep roots, of course, like always, like play the game of like point in any direction and you can like see, some expression of white supremacy or colonialism. And so, so that is true for eating disorders and gender.
Yeah, systems are always big roots, I feel like. And I think it's just important to keep talking about and keep highlighting, because unless the roots are pulled up, it's important to acknowledge that the roots are there. So I appreciate both of your feedback. And I know that was a very oversimplified version of all of it. And in terms of more, tactile ways that providers or people who are in the eating disorder field or wanting to work with eating disorders and or trans folks and or try to really be affirming with both, what are, some ways that practitioners or, even like mutual aid specialists, lived experience experts can practice affirming care?
I would say number one is unpack your own biases and isms. I think that's it. I mean, I think a lot about this. I've taught, trans health stuff to so many different audiences over the years, and I don't get why it sticks sometimes, and sometimes it really just doesn't. And because there's just so much unlearning that needs to happen. And it's not because someone didn't hear what the information I presented, it's because they had a lifetime of other information that counters it. So you can't hear it once and get it. And so, yeah, I just, what was the question?
Tactile ways in which individuals can.
Oh yeah. Unpacking your own stuff, right? Like even just, in the eating disorders field, how much are people steeped in these ideas of like, oh, a curvy body is a feminine body, or like an androgynous body must not have any secondary sex characteristics, and like these really limited views about what it look like. What does a non-binary person look like? I mean, how do you even answer that question? And so unpacking like these things around gender, unpacking these things around food. And, I think a lot of people in the eating disorders field have untreated eating disorders. Yeah, I mean, there's a lot there around like, how can you really support someone in body liberation? And not that like it's something that any of us can fully attain, like it's something that is a work in progress every day, and that's, I guess I didn't say, lived experience with eating disorders, and so, yeah, it's never going to be like full body liberation, especially under this, in this context of capitalism and white supremacy. So, yeah, anyway, I'll stop there.
I always think like by the books written by the people that have lived the life, right? I even wrote down in my notes for today, like buy San's book, like just go do it. Or like I saw my friend Katie was on Katie wrote a book on trans and gender nonconforming people and body image. Like, buy the book, read the book, get supervision from the people with the lived experience, get therapy and consultation from people with lived experience, create peer supervision groups, take the colonialism out of your life by welcoming in the things that you need to learn from, and pay them for their time. It's like my biggest pet peeve is, and this is not to my friends, it's different, but when someone who doesn't really know me messages me on Instagram or Facebook or sends me an email and they ask me a question about a client, which, like, one, don't get me started, don't ask me about clients on social media. And then two, they want information for free that shows me they haven't done the work personally.
Oh yeah. I always complain about this. When people are like, hey, do you have time for a quick question? And I'm like, well, if you don't know the answer to the question, you don't know that the answer is a quick answer. And so like, I don't know, that is labor right there.
Yeah.
So, and there's really great people doing this work, especially BIPOC and trans and queer folks who are doing this work and, not accessing, these roles in institutions where they're getting seen as credible. But I don't know, I think the shift towards valuing lived experience has been a really positive one. And I think it's very new of the last few years. And so, if you are wanting to learn about trans experience, go to a trans person or a non-binary person. If you're wanting to learn about working with people of color, like, don't read books written by white people, about race, So yeah, I don't know why it seems so obvious, but trans health is very cis-led in leadership. So, and same with the eating disorders field.
Agreed. And those are the people making the guidelines about how, like, for example, Sand, how you and I are supposed to do our jobs when we have lived experience that actually says something different.
Mm-hmm. Oh yeah. Well, yeah, lived experience is seen as a liability a lot of the time, rather than an asset.
Agreed.
And I really love that that we're starting to talk about this, because that is one thing that I really wanted to touch on too. I feel like, as Stan was saying, like, lived experience is finally being seen as more valuable in the past few years. And as again, it should be, because care overall is individualized. It is person by person. And again, just because one individual has an identity doesn't mean that's going to apply to another individual with that identity. And so I'm wondering, and I find it so interesting too, that I've witnessed the more marginalized the people are, the more the more likely it seems like they are to speak about their humanness and their humanness in the work that they're in and the careers that they're in. And I'm wondering how, Em and Sand, how your lived experience has impacted your work and how you go about practicing, your job or career or passions.
Rock, paper, scissors. So I think I can say this. I've been in the field a lot less time than Sand and have a lot less experience. And that's not that mine means less. It's just to say, part of my story is I developed an eating disorder at the same time that a family therapist told me to keep my gender to myself. I hadn't hit puberty yet, and no one knew what was happening. And then I spent my entire life till I turned 30 and was working in this field, realizing that the things I was doing was actually an eating disorder. And then I couldn't get treatment because for my career at the time, if I got treatment, I had to go to the people that I was working with and was training. So I had to find outpatient providers that worked with me beautifully and have been nothing but wonderful and have been in recovery for long enough that it feels good to do this work. But I couldn't transition in the way I wanted to until literally the end of September. So my top surgery was 9 weeks ago. I know it's so exciting and so amazing. And it's been so beautiful to like come out to my clients and share this process and show them that like recovery and your transness can live in the parallel process and heal at the same time together. And it's been so beautiful to give that to people and be witnessed in that way and to find who my people are and who my people aren't in that process. And what would have been like if, oh, I'm going to start crying. If 8-year-old me had just been told you are fine how you are, nothing about you is a secret. Your body is not wrong. Your identity is not wrong. We're going to sit down with your family and you're just going to do you. What if someone had done that? I would like to think I would still be the most amazing, fabulous, magical person. Maybe I wouldn't have been, but it would have been really nice if 8-year-old me had gotten that. And what's really cool is now in my career, I give 8-year-old me that every day. And every client I see, I give 8-year-old them that every day. And I don't think someone that doesn't have lived experience can give that level of empathy or understanding. And it's no offense to people that don't have it. I just think it's different when you've done the struggle.
Absolutely. I think it's really interesting that in the substance use treatment world, it's really the norm to have lived experience and for people to be in recovery, and people, it's not the norm in the eating disorders world. I always thought that was really weird. With me and my lived experience, there's a lot that I could say, but I'll share a couple things. Like one is that, I, at the same time, as I was being told as a 5-year-old to lose weight, and started dieting, I was also very much in a dance world. And that is incredibly gendered, incredibly fat phobic, and so I've danced all my life. And it's confusing when it's a place where I also feel like I can be the most in my gender. Like it's this weird kind of thing where I'm like, this world is kind of fucked up, but I also feel like when I'm moving and when I'm dancing, that's where I feel actually the most free, and I actually don't have to be in a gender. And so, but that has certainly been a big part of my story. And thinking that I got into, I don't want to discount that. I got into eating disorders recovery when I was fairly young. I think I was 19 or 20 when I started really, kind of working on it. But for years, I was not in full recovery, and I was still in, such immense fat phobia and like kind of healthism, like the world of like hacker, like, I don't know, those like body hackers, like people are trying to like hack the body, that idea. Like I was kind of like, very drawn to that too, as like someone who's like very perfectionistic and wants to achieve. And so I was like in that, I was full on dieting. I had no idea, because I was in so much restriction. And what really did it for me was to get into a really bad relapse into restriction. That was directly related to gendered medical care. When I was seeking medical care and, dealing with, a field of medicine that is incredibly gendered, it was really traumatizing for me. That's when I really started to get more into restriction and control. And I had no thought in my mind of, I want to look a certain way. I want my gender to look a certain way. I don't want to say that my gender and my aesthetic doesn't have something to do with my eating disorder, but it really was about the pain that I was feeling in this very gendered, environment. And, I like just lost it. Like I just like completely lost it, went into control mode. And so, I think that it's true. I would say it's probably more common than we know for that very gendered medical setting or school setting, or like all the ways that we're interacting, for that to feed into a sense of, I feel powerless. And I'm going to try to find some way to feel a sense of power and choice in my life. Of course, we have to survive. So anyway.
Yeah. No, and I think the reality is like, there is so much, we know that there's power in vulnerability. So there's power in lived experience. And I think a lot of times, especially, with certain like zero disclosure policies or things like that, that kind of gatekeep someone's humanity, someone's humanness, someone's individuality, it can be so difficult to find the middle ground of like what to share, what not to share, when the reality is it all comes with you, right? Like you can't just leave. You can leave your uniform at the door, but you can't leave your past. You can't leave your lived experience. That comes with you everywhere. And I think that's one really important thing to highlight about lived experience and why it's actually so impactful to bring with you in the room, because, well, number one, it's not going anywhere. That's why you always got to check yourself. But number two, it's like that is a part of why people want to work with you, and what makes you good, what makes you good at your job. It's not a detriment, as it's so often seen as, in eating disorders. And so like not only not shaming, but not only welcoming, but celebrating the lived experience that everyone brings to the room, I think is so important, and is something that I think everyone can work on within this field too. Like, let alone if you have any more marginalization. And, one thing I wanted to talk about that, it's funny though, when I think about it, because it seems almost a little bit utopian of like, what would the impact of gender affirming care on long-term recovery be? Because unfortunately, we don't have the research. And not only do we not only have the research because this hasn't been implemented for long enough, but also I think the reality is, and one thing that I just want to highlight is so often people are looking for research and numbers of individuals when, like, if the research is already founded on like privilege and colonialism, like you're not going to find the research on the people that you're wanting the numbers for. But so research in that way aside, like what have the two of you been able to see with clients or individuals that you've worked with who've been able to be affirmed by you for periods of time, and the impacts that, creating that community has had on them?
I always look at it like we can prevent death by suicide. We can prevent substance use. We can prevent long-term health issues by showing up and being affirming and beyond. We actually can prevent all of the other things that go along with all of the other things. It also means creating equitable, sustainable recovery. Most of my clients are on Medicaid. They cannot afford the food that one needs to recover by kind of like cis white standards. But when we move past that system and we move into the system that actually looks at, well, what do you actually have? What resources are actually available? What can I actually do for you to solve a tangible problem, to help an untangible problem? That's when you see things really happen. And I have clients that started seeing me that, were in the throes of their eating disorder who, someone just changed their name this week and they finally got approved for surgery because they weren't medically stable enough before, again, by the system standards. But we know that, if your body's not in a place because it's malnourished, it needs to be in a place for someone to do those things or to have hormones. And I just think that, like, honestly, the easiest thing that is asked of us is to witness people. And I think that's the most healing thing, is when someone shows up and you witness them for them. In art therapy, we talk about that there's two knowings. There's the knowing in your brain and the knowing in your heart, and the two meet when you're witnessed. And so that is the most beautiful part of my job, is when my two knowings come together and I witness someone and they are seen as themselves. And if my room is the only place they get to be seen as themselves, they get that. And that hope and that beauty in that moment is what creates that opportunity for long-term recovery to finally stick. And I don't think that's a lot to ask from other providers.
All of that. All of that. And I think I want to just like kind of respond to the what you said, Ames, about research, even, because I do think that this large survey study by Deemer and other folks, there's lots of names, really changed things so that the eating disorders field was like, oh my God, we had no idea that trans people had eating disorders. Like, I do think that this study is like, it's cited all over the place. And I kind of resent that. I'm like, really? Like, you know, sometimes research is like, research showed that social support, you know, decreases, you know, depression. It's like, you know, we knew that. That's kind of irritating, but it's also really important because that's how we get things like funding. That's how we get people's attention that aren't connected to communities that are marginalized. There is a study, there's not a lot, but there is a study that I often do talk about, which is balsam and Testa. It's Testa, balsam, writer, I forget who else, there's one more person, and it looked at people who had eating disorder symptoms and who were about to access top surgery, so masculinizing top surgery or chest surgery, and it showed that people were able to access top surgery. They didn't even get eating disorders treatment, but that their eating disorder symptoms actually decreased significantly. And so I think this is really important because, you know, the gender affirming healthcare and, you know, transition related healthcare, hormones and surgery, those are mental health. That's mental health treatment. It's not just medical, right? And so I think that's just an important study, and it just kind of says what we already know, which is like, hello, giving people access to be themselves is going to reduce mental health problems and eating disorders. And so that's obvious to me. And then I just love what you said, Em, about witnessing, right? And I've been playing a lot with this word this week of withness. Withness. I don't know why it cracks me up, but I love wordplay. So, but just like feeling withness. And I, you know, a lot of the work I do is internal family systems based. And so I want someone to feel cared for and supported by me in our, you know, working relationship. But more important than that is I want them to feel like they're, you know, want their parts to feel like there's cared for by them, you know, that they're being witnessed by themselves and that they're feeling like they're being attuned to. And so building that relationship that someone has to themselves internally, I think that's where I've seen the most powerful change. And I think for me, that's, you know, kind of, I love using that approach with IFS with eating disorders, because there often is so much internal conflict and turmoil, especially when people start to get this knowledge around like, oh, wait, I'm in my eating disorder. Wait, but I'm fat phobic and I'm into, you know, I'm a social justice advocate. And how does this all work? And so I think there's, yeah, I just really love that. And so that's what I love is like, yes, the research can tell us these trends around 15,000 people who took the survey, but what's most important is what's happening with this person and within this person who's in the room or the Zoom or whatever, you know, right now. So yeah, it's really powerful work and I love it. You know, I love that, like, and it's part of my healing process too. Like when I witness other people healing from eating disorders, it's also, you know, I'm affected by that. So, yeah.
And I think, again, going back to like the power and beauty of lived experience is that it gets to be selfish too, right? Like this is also your life and your journey and your humanness and your experience. And so there gets to be a really powerful, like parallel experience happening that sometimes gets to overlap and intertwine and be parallel. But I really just appreciate you both so much for sharing that. And we got a couple questions, but we definitely don't have time to answer all of them. One question that I think could be helpful that seems to be coming from a provider is that when it comes to allies or individuals working within or with trans, intersex, non-binary folks, what are some maybe common mistakes or mishaps that you see, and maybe like easy ways to either prevent them or fix them, or maybe just like non-inclusive things that you witness often that mean no harm, but can really harm people, and just kind of simple ways to be more inclusive and affirming.
Misgendering, obviously, mispronouncing, body appraisal and surveillance, making comments about people's bodies, categorizing them as masculine or feminine, telling people to just accept their bodies as they are when maybe they need to change their bodies to feel like they can accept them. Just gaslighting, like, just saying you shouldn't be upset about this because I don't want to be upset and uncomfortable. So, I mean, there's just so many things that happen in treatment.
Agreed. I said to Ames before we all started, a provider had mispronounced a client and had said something to the effect of, we should all learn to practice more forgiveness because the client was upset.
Oh.
And I am enraged and fixing it. And I think we can all hear what's wrong with that statement. I will forgive you if you step on my toe, but if you tell me I'm not who I am, there is nothing to forgive, and all therapeutic rapport has been damaged when you come back to me with my hurt being that I couldn't forgive.
Yeah, it's also our societal fear of anger.
Yep.
And like, oh my God, don't get, as soon as you're angry, you're seen as a problem. So yeah, I think that. And then there was one more thing I wanted to say about that is just, I forget now.
That's okay.
It's gone. I'm done.
And then one more question that is coming from a parent is just wondering ways in which they can be supportive or sensitive to specific issues, or concerns that might be coming up. Their child is non-binary and just got out of treatment, and just wanting to really help support them in things that might be more sensitive or more specific to being non-binary and in recovery.
It's hard to say, kind of not knowing the young person. But I think it's just about like, how can you listen and make yourself available and really trust that things will be shared as they feel, as the young person feels safe doing so. But I think just even the fact that the person's asking the question is a really good sign, right? So.
Agreed. I was going to say, you're here, so you're doing something, which is amazing because not every parent is here. And I agree with Sand. It's hard to know unless you know who the kiddo is. Ask. It's okay to ask. I know the most beautiful thing in the world is when someone doesn't know an answer about something related to my gender or my pronouns or my name, and they just ask. I know not every kid wants to be asked, and you're a parent, so you're apparently really annoying and not cool, but ask anyway.
I think especially showing up to things like this and not being asked to do that, right? I think that's a really huge step because I think one thing that's really important to highlight is that, affirming trauma-informed care, it doesn't start with your client. It starts with your social circle. It starts in your house. And more importantly, it starts alone in your room, and really being able to unpack and unpack your own stuff, and then show up and learn in the places that you feel you need to. I am aware of time, but I do just want to shower both of you with love. I am very, very happy that you were both a part of this conversation, and that you both do the work that you do. I really appreciate everyone for being here. I hope everyone was able to take from this what they needed. I will be passing along the questions we weren't able to get to, and the video should be up in the next 2 days. And if anyone is needing any more support or any more specific resources, you can also email Sabrina. I believe at the beginning of this meeting, put in our info email, as well as and Sam's contacts and social media. And so thank you all for being here